Hi, this is Colin Hung, editor at Healthcare IT Today, and I'm very honored to welcome my good friend to the program, Jane Sarasohn-Kahn, trend weaver, author, speaker, health IT advocate, and 2020 Medici Hitmake Award winner for Health IT Advocate. Thank you, Jane, for being on the program today.
Thank you, Colin. Love being with you.
Now, Jane, I've got to ask, since you are a trend weaver, what in your mind is the biggest challenge facing healthcare IT today, healthcare today, other than COVID?
Other than COVID, well, we entered COVID still using fax machines, and I put a piece on Twitter yesterday about fax machines getting in the way of COVID. It's hard to think beyond COVID, pre-March 11th when the World Health Organization used the P word, pandemic. It's hard to remember what life was like, but 2 weeks before that, HIMSS was canceled. So let's start back to, leading up to HIMSS, where were we? I think the issue of digital transformation, everybody talks about, but it's just this mantra that becomes marketese. And really what we need is real digital transformation. The excitement is, I think we're getting there. The ability now through FHIR standards and APIs to appify what had been a fairly closed medical record. The fact that patients, caregivers, consumers are feeling like I need to make health more. COVID has again accelerated that trend a lot in the stay home era, but more and more care being done at home in the community. So we need data to be liquid, to flow where it needs to go. And that's, I think, the next challenge is that. Coupled with that, though, is privacy, which doesn't get talked about nearly enough or addressed. And I think in 2021, we'll see that addressed more legislatively in the US, where we need something more like a GDPR privacy standard. We can dig into that if you want or not. I won't go into details, but I think the liberation of data, which will then lead to the concomitant need for privacy legislation beyond HIPAA.
Beyond HIPAA. So you mentioned care at home, and of course, even before COVID, that was a growing trend, albeit probably slower than most people who are in that business wanted to grow. Do you see that becoming a real thing? And if so, what are some of the barriers that you're seeing to that really taking off?
Yeah. So we've begun to see, and again, COVID's an accelerator, hospital to home movement, which I've been advocating for a few years for safety, for costs. I'm a health economist, and I think we can do this if we deploy and reallocate resources the right way. That isn't just home health aides and occupational therapy in the kitchen. That's real live acute care and even some fairly critical care to the home. What do we need to do? What are the barriers? First and foremost, connectivity. So the FCC will talk about broadband to the last mile. It should be broadband to the last phone and to the last home, to the N of one. It's not a mile problem. It's an individual problem. And many individuals, and we've learned this through COVID, don't have enough money to pay for broadband to the home, so that kids who've been forced home for school often didn't have the connectivity they needed to connect to their teacher. And so this is Wi-Fi is a social determinant of health, I've been saying for a few years, and that's gotten acceptance now. So I wrote about it in Huffington Post a few years ago, broadband is a social determinant of health. AMIA took that on, the Medical Informatics Association, and now I think we realize Wi-Fi is key. So that is the first huge barrier. Got to get it everywhere. It's a utility. It's like clean water, clean air, and we have to take that very seriously. Number two, getting the supply side and the demand side together on this. So let's say a healthcare system wants to move care to the home as appropriate for low to middle risk patients. Is the patient ready? Is the patient literate in the variety of ways they must have that level of health literacy. So it's not just knowing when to take my medicine, which is part of health literacy, but it's digital literacy. If I place a remote health monitoring device in your home, will you be able to use it? And that then gets to the next barrier, which is design. Design is the opportunity to address that barrier. We need to bake brilliant, enchanting design into healthcare and into health workflows for patients and clinicians. Obviously, EHRs were brilliantly and enchantingly designed by Steve Jobs or Walt Disney or P&G, because of course we have physician burnout dealing with EHRs and the post HITECH Act adoption. But design for the home, for people who are fragile, for people with multiple chronic conditions, for older people, or for little people, for kids. Everything must be designed with the end user in mind. And I've been so educated by this by my daughter, who went into service design. She went to Savannah College of Art and Design and graduated with a real degree, a BFA in service design, part of the digital design department at SCAD, the only undergraduate department for service design in the United States. Came out of Europe, important. And Anna has taught me a lot about this. So God bless the child. So you've got broadband, you've got these many layers of literacy, and then on the clinician side, the health system may want to put up hospital to home, but do clinicians really want to engage in this way? And will payment follow? So ultimately, we always come to payment. I'm not going to use the word reimbursement anymore because we don't want to live in that volume-based world. Hospital to home is by nature a value-based concept. We're going to lower costs, we're going to improve quality, we're going to bring the whole care team, very multidimensional care team, including the family, on board for shared decision making, thereby enhance the experience, lower costs, improve outcomes, and enchant clinicians so we prevent burnout. And they're really burned out in the post-COVID, in COVID and post-COVID era. And clinicians came into COVID already pretty burned out and depressed. So we've got to really attend to design and mental health for the clinician and the patient as well. So those are a few of the considerations of hospital to home.
I love how you succinctly put those barriers, because I agree with every single one of them that we're going to have to overcome. But like what's happened with the work at home movement, where suddenly people have realized, oh, I can work from home. I hope that the same thing will happen about care at home, that people can realize that, hey, I don't actually need to go to the healthcare facility. I can do something via telehealth. And if I only had a few other devices, I wouldn't have to go in. And the home has turned out to be a lot safer place to be during this pandemic as opposed to any of the institutions. So hopefully,
I think you hit on something. I mean, I think CVS now is leaning in this direction now as a payer, integrated sort of payer provider. I think you look at, Walgreens investing in Village MD, $1 billion to create that primary care network. So care moving closer to home, and then to the home. I think you're spot on, because COVID's taught people that there are risks. And so as our kids might have talked about fear of missing out, FOMO, in my book to come, I talk about fear of leaving home, FOLH, and the risk of going to the grocer, going out. When I'm that terrible finger wagging person out when people aren't wearing masks now, I'm terrible. But I mean, I'm a mask person now, like 24/7 out of doors, and even just taking a walk. So I think the fear of leaving home, for not everybody, but for many people, and particularly people over, say, 50 or 55, particularly if you have a pre-existing condition, it's a real thing. So I think that will be a driver of adoption for hospital to home.
and we do have a question of cost. Is it actually going to cost any less to do care at home? I mean, the theory is, of course, that it is, because you don't need, you don't have the overhead of the entire building and as many staff and so forth. But even if not, there's sort of a mental health aspect of just being able to be at home and get the care you need and not having to fight traffic or or having to get on transit and find parking and all those things that come with visiting a doc. And you mentioned, of course, social determinants. That is one of the determinants that prevent people from getting care in the first place, because they have to take time off work and so forth. But if I'm able to do it at night and get the care I need, and therefore be in the workforce longer and healthier, that can only help the economy, which right now needs any boost it can get.
And the experience that helps you heal better by having, say, a doula for your birth, or a diabetes educator come to the home and help you mind the fridge for healthy food, or a massage therapist that helps you with some meditation maybe at the same time. All of that multi-layered approach to caregiving helps drive better outcomes at the end of the day. Then we reimagine what that building with beds can be to serve people who are very, very sick, to keep capacity for the next pandemic, because there will be one, and then to play a different mission in the community, but that multi-layered mission from hospital to home, and stay relevant that way, because the hospitals have to reconsider now, what are we in the post-COVID era, given how broke many hospitals are financially, coming in it and coming out of it. So I think there's a big revisit of what is the future of the hospital, the nature of the hospital. And many organizations are talking about that. Certainly Philips is pivoting in this era to hospital to home. Intermountain, from the provider point of view, looking at hospital to home. So some very smart folks are already envisioning this and creating solutions and learning as they go.
On a recent, or maybe not so recent podcast, John Lynn and I explored this topic. And one of the companies that I had said that I would love to see get into the home health and the care from home market was IKEA. Right?
Yes.
Imagine going to IKEA and being able to go down an aisle and kind of go, oh, I need this, I need a bed for mom, and so I can buy this one, which is built more from a medical standpoint. Here are some other pieces of furniture, and even one day maybe devices are available there. And you can imagine the IKEA design aesthetic, and as you said, how beautiful that would be to have those kinds of options for somebody who wants to be at home.
I actually know for a fact that IKEA is looking at this, and that's all I can say.
Okay, all right. Thank you for that inside tip.
You're pretty smart. They've been in the IKEA Israel franchise. They've looked at mental health. There's some beautiful YouTube videos they've done, and I'll send you the link so you can post it, because we talked about it. You can post it on the site. But IKEA's got wellness on the mind. They're based in Northern Europe, so the cultural tendency is there to ask that question. So they're all into sustainability, of course, now, and thinking about wellness. So keep your eye on it. You're a smart guy.
Well, thank you for saying that. But I do want to go back to something you just touched on, and being a healthcare economist. And that's how I first knew you, by the way, as a healthcare economist. There's a concept that is difficult for a lot of my friends who aren't in healthcare to understand, and that is this fact that hospitals are actually in financial difficulty. In a time of a pandemic, they are believing that hospitals and healthcare people are making money hand over fist. And yet we know, who are in the industry, that the hospitals are struggling, healthcare providers are struggling. How do you kind of marry that together? Because there isn't a public acceptance of this fact, and so it's not in the headlines yet. But it's a looming problem as this COVID pandemic extends.
Yeah. So we go back in health economics to the great, sadly gone from the planet, Uwe Reinhardt's seminal article in Health Affairs called "It's the Price is Stupid." He said that with respect. But "It's the Price is Stupid" was Uwe and his teams, Gerard Anderson and others, look at how healthcare in the US is priced versus other parts of the world. And that's why I really love when people can work in other countries to really learn about how healthcare is delivered on a fraction of how it's delivered in the States. But it's the prices. It's what we charge And in the US, the prices for medicines, the US bears the largest cost for innovation in pharma. We pay more money. We don't allow Medicare to negotiate with pharma for drugs. So our drug costs for patients and for the system, hospital price drugs, are higher than anywhere in the world. We are highly capitalized in terms of technology, a very high percentage of MRIs per capita, blah, blah, blah. So hardware costs, but the largest cost in a health system is labor. What do we pay very highly specialized surgeons, for example, the proverbial brain surgeon, versus what we pay for primary care professionals, internists, OBGYNs, pediatricians, much lower relative to the brain surgeon. And we've made some sort of decision, not transparently in the US, to pay primary care professionals much less, when in fact we should pay them a lot more. And maybe the specialists might get less, because the ROI on primary care and prevention is so much greater than saving a life for 1 or 2 years. And I don't say that with a cold heart. I'm talking as an economist looking at quality adjusted life years, which is one of the acronyms we talk about in economics, QALY, or QALYs, looking at what does it cost to save a life or prevent, blah, 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 all the way down. So labor costs a lot, and why? Well, we pay higher wages to some people, lower wages to others, and that needs a huge revisit, which is why when we think about pivoting to hospital to home and that multi-professional, diverse network of caregivers, we can substitute expensive doctors who we could conserve for things in hospital, in the office, where we need those cognitive skills, to nurse practitioners, physician assistants, diabetes educators, foot providers, right, for people with diabetes, all kinds of people in the home, and save money that way. So prices, and then how we allocate resources. We make these decisions based on payment, what we're going to get reimbursed, which is why we need to leave that world.
Well, and I think, if anything, this COVID crisis has highlighted the hospital, well, in particular, I'm picking on hospitals, but their dependency on elective, or what's deemed as an elective procedure. And clearly, providing the basics of care isn't profitable, which is really ironic to think about, because that isn't the goal of healthcare, but that they need those electives in order to balance the books.
That's right.
And I hope that there's going to be a reckoning or a recognition that, okay, you know what, we're not paying enough, as you said, for primary care. We're not paying enough for the basics of health, and we're paying perhaps a little bit too much for these very, very, very specialized, perhaps in some cases unnecessary services. So that's going to be very interesting to see how that plays out over the next little while.
The additional cost on that is extending end of life unnecessarily, and in the US especially, we've been allergic to that conversation, and we also have to have that one. We certainly had that conversation in my own family's life, with my mom, with my dad, who lived much longer, well into his 80s, but he had heart failure at the end, and he kind of wasn't real happy the last year of his life. So there might have been a different solution, his choice, whatever. Anyway, he died peacefully. But I'm just, end of life is also a cost that we choose to bear in US healthcare. So I think that too we add into the whole discussion of really, and why I want to write this small ebook in October, a month before the US election, is it all depends on November 3rd for the US now. It all depends. Health policy, and one of the things you and I are talking about, it's going to go one way or another way after November 3rd, or by January 10th, 2021. And it's a big election.
That gets into two areas that I don't tend to wade into, which is A, politics, and B, predictions. So
right.
I will politely avoid talking about November 3rd.
Yeah.
But let me ask you this. I mean, there is no doubt, whether it's November 3rd or whether it's right now, we are at a historic moment in healthcare. There's been upheaval in society, with racial inequality and inequality in general, and that's caused us to look inwards. There's, of course, the COVID pandemic happening. There's a huge confluence of challenges. But this is also a time where new ideas and new technologies have a chance to take hold because the rules and the barriers are down, right? We're seeing something now that I never thought we'd see, which is the permission for doctors to practice across borders, like state borders, right? Like that was, to me, like that was sacrosanct in U.S. healthcare, but now that's come down because of COVID.
Yeah.
So in your opinion, is there a unique opportunity right now? What unique opportunity do we have right now if we can only but seize it in terms of a new idea or a new concept that could take hold?
That's absolutely right. I mean, you lowered the barriers in the pandemic, and it took a pandemic for telehealth visits to go from a couple dozen a month to a couple thousand a month for any average US health system now. So that's been one of the gifts of COVID, and there have been gifts. We're seeing great art coming out of COVID and great soul, and this realization, as you point out, that things aren't fair and for too long. So it seems a majority of people in the US actually agree with that statement. I have lots of data around that I've been talking about and that I'll write about more. So yeah, we're in this opportunity to inspire a more equitable and just health care system that really focuses on the public's health. Underneath that, there's this chasm we have to jump to, which is, are we our brothers and sisters keeper? Do we really love each other? Do we really care about each other? So Alex Drain and I, a lot of people know Alexandra Drain, and we've been talking about love is the next big industry. And she had a conversation with Marcus Osborne of Walmart about this online the other day with respect to behavioral health. But we really know wearing a mask is a sign of caring about you, not me. And if you wear it, you're caring about me. So these are new life flows, new workflows. We're learning. This is a new kind of health literacy we're learning about. We're learning what flatten the curve meant, which is stay home and stop the spread. That was a good thing. We did that for each other. So that is part of this opportunity. It's both the tech, as we've talked about earlier today. It's not just about the technology, but it's about the political and social and moral will to do this. Is this something we want as a society? And I'm hopeful that we're going to get there, because I do read these surveys and polls incessantly, and I weave them together because one is one and you have to do 10 of them to really see what's the median. But I think we are getting to this point where we know it's not just technology, but we need the technology, but it's also using the technology for good, for the most good. And also one of these converging factors you didn't mention is the sad economy. We're going to come out of this broke. Canada's, going to have deficits. The US, Europe, the whole EU, where I spend time working as well, broke. So taxes will go up, and how we allocate the next round of monies toward climate change, toward health, toward food systems, toward transportation. Those all feed into health. So I think that's the big picture opportunity. And then the specific one that you're talking about, virtual care. We need to keep the barriers as low as possible to continue this going. And I know the American Telemedicine Association, the ATA, is working tirelessly at this moment, educating Congress. And interestingly enough, in the Senate Help Committee that met a few weeks ago, where Joe Kvedar spoke and others in the virtual care industry, Joe's the president of the ATA, and of course is up at Partners in Boston as well. There's bipartisan agreement that telehealth is a good thing. We don't have bipartisan agreement on anything in the US. So, I mean, this is kind of a holy grail where we're seeing kumbaya. So that's also part of the solution. Is there political will? Yes, I think. So again, there's momentum. Let's keep this going.
Well, as usual, Jane, when we get together, we could go on for hours and hours. And, we've explored so many amazing topics in our discussion today. So thank you for that. But let me ask you one final question to end on, and that is, what advice do you have for other health IT advocates out there like you are, people who are pushing the envelope and giving voice to what should be voiced? What advice would you give them who are now not able to go to conferences and not able to speak with people one-on-one in the way that we used to?
So, two things. I can't just do one. First is the importance of your social network, your work network. So I have a lot of work wives and work husbands that I know for years. I know I can count on you if I have a particular question in social networks, marketing, communications. That's not my bailiwick. So I turn to you and John and others in your field. But you need this social network now more than ever because we're not seeing each other in meetings, in conferences, live. So having your carefully curated network of key opinion leaders who buoy you, who inform you, who challenge you, who teach you, your tribe, that's really important going forward, not just for a health IT advocate, but for anyone who wants to really fully engage in their career. And I mentor a lot of younger people, and I'm very specific about this with them. Specific now to health IT. Health IT is so broad now, as we've talked about. It's not just the EHR, it's not just a billing system, it's the cloud and it's the internet and it's e-commerce, for God's sakes, and what Zelf is doing. And, it's so much broader. So you think about the role of Alexa and voice and Amazon and smart cities and Internet of Things. So my advice is find an area within this whole ecosystem of health tech, health IT, where you're passionate
Mm.
and know everything about it. Eat it up, drink it up, live it. I mean, this is when I chose to sort of rebrand and be specific in the last 15 years or so, with the great help of Andre Blackman, in fact, helping me think this through. I was focusing on the emerging consumer in health, so the consumer health and technology. And that's really what I have focused on relentlessly for half of my career now, the latter half. If you love what you do, you will have a beautiful, full life. You will create that network and you will contribute in an authentic, really impactful way. But it's hard to choose. But I think if you find that thing that you love, that you're passionate about, and for me, it's that person, the technology, and the health, you can work many more hours in a day than you think.
Well, Jane, thank you so much for the wonderful insights you've shared with us today. I really, really sincerely appreciate it. You are a gem, and I am so honored that we are friends. So thank you for being on the program.
Oh, thank you, my friend, my fellow Canadian.
This has been Healthcare IT Today, and I'm Colin Hung with Jane Sarasohn-Kahn. Thank you so much for listening.